So we all have a concept of a personality, right? People can have an extroverted personality, they may be kind, cynical, arrogant, or any number of adjectives. In short, it's a way of perceiving, thinking, and interacting that kind of makes up your signature style. No, you don't have to memorize that, by the way. That's just my way of remembering it. But what you do have to remember is that personalities consist of enduring traits. Someone's mood can change, they can conquer their fears, but after a certain age, personalities will endure and continue to define them. Basically, a personality disorder means that you have a critically flawed personality. Now, I know to some extent that this is a subjective assessment and also sounds kind of mean, so to be more specific, a personality disorder is where a group of personality traits is not only maladaptive, but inflexible and rigid regardless of the circumstance. Personality disorders require that either the personality causes the patient distress, or the personality causes impairment in functioning. Truth be told, most patients have no idea they have what's considered a disordered quote-unquote personality. To them, that's just who they are. And this combined with the fact that, yes, really, that is who they are, makes dealing with personality disorders very difficult, if not impossible to treat. Therapy generally focuses on coping mechanisms because there's no drugs that have been invented yet to change someone's personality. Maybe y'all can work on that. We'll be talking about 3 clusters of personality disorder, grouped by common traits. Cluster A, which shares some features with psychotic disorders, Cluster B, which shares a few features with bipolar disorder, and Cluster C, which shares some features with the anxiety spectrum. And just because we like to be mean, we've given them nicknames too. Weird, Wild, and Worried. Cluster A personality disorders have some similarities to aspects of schizophrenia, and are actually genetically linked to the psychotic disorders. Paranoid PD is exactly what you'd think. They believe everyone's out to get them. It mirrors the persecutory delusions found in schizophrenia, but their thinking doesn't quite cross the border into delusion. They just assume the worst about people. Schizoid PD mirrors the negative symptoms of schizophrenia pretty well. These patients seem cold and emotionless and are entirely uninterested in social interaction. There's also a schizotypal PD, and I can practically hear you guys complaining already about the, 5 schizo disorders you have to know? Anyway, these guys are hilarious. They're the archetypal weirdos. They dress funny, they're super awkward around people, and they have these weird religious ideas and ideas about magic that, while not obviously delusional, are pretty far out there. And by the way, if you're worried about mixing schizoid and schizotypal, just remember that schizoid with a D is distant, whereas schizotypal with a T has odd thinking. Anyway, relax, we'll review all the schizos in a moment. The Cluster B personality disorders share a genetic link to the mood disorders, and they all seem pretty unstable, like bipolar disorder. More than that, when you kind of feel bad for the other personality disorders, these folks just seem like unpleasant people. B stands for bad to the bone. These are the ones that are hardest for me to remember because their names don't actually tell you a whole lot about what they are. So I'll try to break it down for you, by distinguishing features and by the similarities. Most of these disorders embody some element of bipolar disorder or mania. Borderline PD, which also starts with a B, is probably the closest to bipolar disorder in that it's defined by emotional lability, extreme highs and crushing lows that extend out to their relationships as well. Now, one thing you have to remember, which defense mechanism did I say was used a lot by borderline patients? The answer is splitting, or dividing one's outlooks or opinions into absolutely good or absolutely bad, which makes a lot of sense when you think about how their emotions vacillate between the extremes all the time. Histrionic patients embody the outgoing aspects of mania and are arguably the least obnoxious of the B cluster. They can really push the boundaries with the therapist, as they tend to be sexually provocative as well. Narcissistic personality disorder, as you may expect from the name, embodies the grandiosity of mania and the need to be admired. It's not quite the same as a true delusion of grandeur, though, as their egos are actually pretty fragile. They react horribly to criticism. An antisocial personality disorder? Well, that one doesn't really embody a bipolar characteristic, but you all know this one from the childhood onset disorders section. Remember which childhood onset disorder ASPD resembles? Antisocial personality disorder is basically conduct disorder once a person turns 18. It's the tendency to violate the rights of others and engage in criminal behavior. But they do have some bipolar or manic tendencies that they share with other B cluster disorders. ASPD is pretty similar to narcissistic personality disorder and that they both feel limited empathy. Sociopaths because they have no problem exploiting others, and narcissists because they're too self-absorbed to care about anyone else. Both of them tend to be arrogant and antagonistic, and both are capable of being very manipulative if they're high-functioning. For example, Charles Manson, who arguably fit both disorders, was charismatic enough to get a following of people behind him who all thought he was God. Antisocial personality disorder also shares borderline PD's impulsivity, but that's about where the similarity ends. Narcissistic shares histrionic PD's need for attention, but again, that's also where the similarity ends. Narcissists are users who don't really care about anyone but themselves, whereas people with histrionic personality disorder do care about other people, they're just guilty of hamming it up all the time. Finally, both patients with borderline personality disorder and histrionic personality disorder are capable of extreme emotional displays. With histrionic patients, though, it tends to be more towards the manic end of the spectrum, whereas borderline patients really go all the way from one end of the spectrum to the other. Plus, you kind of get the sense that histrionic patients are being over the top on purpose to get attention, whereas the borderline patients really are actually emotional train wrecks. Seriously, these guys have a very high rate of mutilation and suicide. Finally, the last really high-yield factoid for step 1. Most patients with personality disorders unfortunately can't be treated very well. But there's one personality disorder in the B cluster that actually does respond to a specific kind of therapy. Which one do you think it is? Hint, it's definitely not ASPD. Actually, dialectical behavioral therapy gained some recognition a while back for being able to manage the symptoms of borderline personality disorder. You don't have to know what it is or what it does, just know that dialectical behavioral therapy is associated with borderline PD. Cluster C is the anxiety-like cluster and is genetically linked to the anxiety disorders. These are pretty easy to remember because their names sound exactly like what they are. Avoidant PD is a lot like social anxiety disorder, except this is a pervasive lifetime pattern of avoiding social interaction because of extreme feelings of inadequacy and a hypersensitivity to rejection. Social anxiety disorder, in contrast, isn't usually due to an ingrained feeling of worthlessness. It should also be noted that while both the schizoids from cluster A and the avoidants from cluster C tend to shy away from society, they are incredibly different. Avoidants are too shy to say hi, but the schizoids don't care that you're there. I gotta write that one down. OCPD is what everybody thinks of when they call people OCD because they think they're being anal. These guys are perfectionists to a fault, preoccupied with neatness, and most importantly, they believe that their way of doing things is the right way. As we talked about earlier, this separates them from patients with OCD. Dependent PD is a really sad disorder. They take on a submissive role and they can't really make decisions without a caretaker or a friend there to help make them for them. The reason this is pretty sad, by the way, is because these people seem to attract jerks like flies, and a lot of the time, they become very dependent on abusive partners. Alright friends, you think you got personality disorders down? Then let's try this flash quiz on for size. Here's the fill-in-the-blank question. Borderline personality disorder is known for using the defense mechanism blank and is best managed using blank therapy. These are two buzzwords you definitely have to know in relation to borderline personality disorder. These patients use the defense mechanism splitting, and it can be managed by using dialectical behavioral therapy. Just repeat those over and over to yourself until it sticks. So, if you're wondering how to keep all the schizo terms straight in your head, First Aid is a pretty good system for this that I am gladly going to pirate and modify for my own use. It's okay, I work for them. So we already did a comparison of psychotic disorders by time, like so. Remember which psychotic disorders fit into which time ranges? Your quintessential psychotic disorder, schizophrenia, requires 6 months of symptoms. It's called schizophreniform disorder when it's between 1 and 6 months, and it's called brief psychotic disorder when it's less than a month. Now let's reorient this time axis and introduce a new axis called the weirdness axis for all the fun new schizos we just learned. Basically, the higher you go on the weirdness axis, the weirder you get. Now, personality disorders are basically like schizophrenia light. Not full-blown psychotic, but still not all there. Schizoid's the least weird. They just sit around like robot people from the planet Don't Talk to Me. Schizotypal people go around looking weird and talking about how the fact that they found a fly in their soup means that they have insect pheromones. So what's weirder than schizophrenia? Schizoaffective disorder. where you're not only full-blown psychotic, but also have mood issues. That takes the cake. Let's talk about eating disorders now, specifically the difference between anorexia and bulimia. Now, right off the bat, if you had to describe the main difference between the two in just one word, what would it be? The answer actually has nothing to do with this. It has everything to do with the fact that anorexics look like this and bulimics look like this. Now I'm going to give you the world's easiest rules in the world for distinguishing between the two. In a patient who ostensibly has an eating disorder, i.e. has a ridiculous weight preoccupation, goes crazy trying to lose the weight, the ultimate rule of thumb is if the patient is clinically underweight, he or she is anorexic. That's it. There's no rule for amenorrhea in the DSM-5. The only thing that distinguishes it from bulimia is weight. Of all the misinformation about eating disorders, this is probably the most important way you can trip up on step 1. Anorexics can actually binge and purge too, but they don't always. Bulimics, however, are defined by binging and purging. Second, purging doesn't just mean vomiting. It can include laxatives, dehydration, or even exercise. But Arjun, says you, isn't exercise a good thing? In fact, it's not the exercising in and of itself that's the disordered behavior, but rather the loss of control that leads to the binge and the subsequent shame spiral that leads to the purge, no matter what the method. So because anorexia is defined by weight, many of the health problems you'll see are due to malnutrition. Remember this from the repro section, insufficient weight suppresses the entire hypothalamic pituitary gonadal axis, often causing osteoporosis and amenorrhea. It can also cause a whole host of other medical conditions. Both bulimia and anorexia can also have purging-related consequences depending on the method of purging. Most methods cause electrolyte disturbance and contraction alkalosis from the water loss, and vomiting specifically can cause parotitis and enamel loss, not to mention incredibly horrible breath. The malnutrition issue is something you definitely need to hospitalize anorexic patients for, but bulimic patients only need to be hospitalized if there's something seriously messed up with their electrolytes. When it comes to the long term, bulimics don't actually have a terrible prognosis. SSRIs and psychotherapy will usually just do the trick. Anorexia is a little bit harder though. While bulimics tend to be impulsive, they can be reined in. But anorexic patients are often harder to work with because they don't tend to be as communicative and are generally more type A than your bulimic patients. Gender dysphoria, or being transgender, is the psychological condition of identifying with the opposite gender you were born into. Now, this is something I didn't realize was actually considered a disorder before coming to med school, but then again, homosexuality used to be a DSM diagnosis as well. Let's see how long this one lasts. I'll give you 3 important distinctions. Transgenderism is wanting to live in society as the non-biological gender, because remember, gender is the social role that typically goes along with a set of chromosomes. Transsexualism is wanting to not only alter the social role, but also alter one's secondary sex characteristics and even genitals, often through hormone therapy and surgery. Contrast these with transvestism, which isn't actually a form of gender dysphoria, it's just a fetish for dressing in the clothes of the non-biological gender. So, if a transgender individual dresses like the opposite sex, does that make them a transvestite as well? Definitely not. Transgender and transsexual individuals often dress in the clothes of their desired gender, but it's not for sexual gratification, it's because that's the clothing they feel most at home in. To make matters even more confusing, there's also a ton of people who dress like the opposite sex, but it's neither because of gender dysphoria or because they want to get off, but just because they feel like it. Now this is called cross-dressing and probably applies to most of whom would identify as drag queens. Just a fun fact. So a patient is brought in by her mother when she's heard throwing up after meals. She's not menstruated in at least 6 months and has a layer of fine hair over her skin. What eating disorder does she most likely have? Now, this is an extremely important fact to remember. In a patient with an ostensible eating disorder, meaning one who has an obsessive fear of getting fat, takes extreme measures to lose weight, and binges and purges as well, this kind of patient can either be anorexic or bulimic. The big difference is the weight. The weight and the weight-related sequelae. If the patient's not menstruating, if a patient's got a layer of lanugo over her skin, you can pretty confidently infer that she is clinically underweight. That makes the patient more likely to be anorexic than bulimic. On the note of sex-related things, let's talk about sexual dysfunction. A while ago, a bunch of psychologists decided that the best way to make sex more fun for everybody was to graph it. The sexual response cycle begins with desire, which in everybody's perfect world leads to the onset of intercourse. Once intercourse begins, sexual excitement accelerates in the physiological arousal phase, up until the plateau, where it stays constant until orgasm. At that point, sexual excitement declines during the resolution phase, though if you're a female, your sexual response curve might look a little bit more like this. Which, in my scientific opinion, is not fair at all. Because each step is required to progress to the next phase of intercourse, inability to pass through any one of them can lead to sexual dysfunction. Hypoactive sexual desire and even sexual aversion are definitely causes of sexual dysfunction. Erectile dysfunction is probably the major cause of disorders of physiologic arousal, and anorgasmia is really the ultimate in bad luck, as you can find yourself all the way up to the plateau phase of sex and just not be able to orgasm. There's also pain disorders that can seriously decrease how pleasurable sex is, such as dyspareunia, which is just a classy name for pain during intercourse, or vaginismus, which is basically an overprotective vagina clamping down as hard as it can the moment something comes near it. Erectile dysfunction is the most common of these, and it can be due to both psychological and medical reasons. So here's a question for you. How can you tell if a guy's sexual dysfunction is purely psychological, without running the whole gamut of tests on him? Elementary, my dear Watson. Ask him if he gets morning wood. No, seriously. If he can wake up in the morning with an erection, then his apparatus is running smoothly, but it's not working during the crucial moment, likely because of something psychological. Maybe he's been married for 20 years and they need to spice something up in the bedroom. Maybe his partner screams at him for not being able to have an erection, and he has performance anxiety. But that simple test, or a nocturnal penile tumescence monitor, is the simplest way to distinguish between psychological and medical etiologies, and that's a fact you won't want to forget for the boards. Because these guys can actually benefit from therapy as well as Viagra. Medical reasons for erectile dysfunction include vascular disease, most commonly associated with diabetes and smoking. A number of drugs can cause erectile dysfunction, including beta blockers and alcohol, leading to the name Whiskey Willie. Finally, drugs like SSRIs and antipsychotics can cause sexual dysfunction in pretty much all phases of the sexual response cycle, both for men and for women. Anyone remember why antipsychotics cause sexual dysfunction? This is more of an endocrine question. Antipsychotics suppress dopamine, which disinhibits prolactin, causing suppression of the entire hypothalamic gonadal pituitary axis. Check out the endocrine section for more information. Talking about sleep terror disorders like that saying, if a tree falls in the forest and no one's around to hear it, does it make a sound? Except in this case, the forest is your slumbering mind, and instead of trees falling, it's the baying of 1,000 unimaginable horrors from the depths of your imagination. Sleep terrors occur during the slow wave portion of the sleep cycle, whereas nightmares generally occur during REM sleep. From the thrashing and screaming that occurs, you'd think that people with sleep terrors were having the worst nightmares in the world. But these people actually go right back to sleep, and when they wake up, they have no memory of what made them kick and scream in the first place. So ask yourself, if a monster peels off your skin in a dream and you can't remember it, is it a bad dream? Now on to narcolepsy. Quick, name the most famous narcoleptic you can. I'm going to go out on a limb and say that about half of you guys said Rowan Atkinson in Rat Race. You know, the Mr. Bean guy? Yeah, he's not really a good example. Really, narcolepsy is a disorder where the sleep-wake cycles go all haywire because of the inability to produce a sleep-regulating hormone called hypocretin or orexin. The most characteristic disturbance is an abnormally early entry into REM sleep, which makes a narcoleptic sleep cycle profoundly unrestful. So the most common symptoms are actually nothing crazier than excessive daytime sleepiness. There's also the hallucinations we talked about. Remember the difference between hypnagogic and hypnopompic? Hypnagogic hallucinations occur as the patients go into sleep, and hypnopompic hallucinations occur as the patient pops out of bed. Finally, you know how Mr. Bean falls asleep standing up randomly? Yeah, that doesn't really happen. Narcoleptics fall asleep a lot while sitting down, just like normal people after about 24 hours of sleep deprivation, or surgeons after 72 hours. The really weird thing they do is suddenly drop to the ground like a limp jellyfish when they feel a strong emotion. Remember what that's called? It's called cataplexy, and it's probably the most specific finding in narcolepsy. It's a hilarious prank you can play on all your narcoleptic friends. Just tell them a great joke and make sure there's some pillows behind them. Alright, now because I'm lazy, this is actually my favorite change to the DSM. There used to be two categories for substance use disorder that were totally non-intuitive and a pain to remember, but now they've all lumped it into one category. Basically, if you have any two of these criteria, you have substance use disorder. If you want to, you can memorize them, but honestly, now that there's no alternative diagnosis, I would just look them over. It's pretty common sense for step one purposes to tell if someone has a substance use problem. Now, whether it's drugs or alcohol, substance abuse is tough to quit. And let's be real, as a grown adult, do you really want a lecture from your primary care doctor every time you're in his office? It's a tough line to walk between genuinely looking out for your patient's health and telling a grown adult what to do, but a good way to broach the subject is to see if they're even ready to overcome their addiction. That way, you're putting the ball in their court. A lot of your patients will be what we call pre-contemplative, meaning they haven't even contemplated the idea of quitting because to them, it's not a problem. At this point, it's kind of your job to tell them that, yeah, it is a problem from a health standpoint, and they may disagree, but hey, you gave it a fair shot. The road to recovery really begins with contemplation, recognizing that there's a problem in the first place. But for whatever reason or another, these patients aren't yet willing to make a plan, and as grown adults, you have to respect that decision. Keep checking back with them in future appointments, though, because ideally, you want to catch them in the determination or preparation stage. This is where they've resolved to do something about their problem, and darn it, you're going to do everything in your power to make it happen. Once you've set some reasonable goals together, they begin on their action plan where they're slowly but surely changing their ways. And here's the important part. This change requires maintenance. As Alcoholics Anonymous says, once an alcoholic, always an alcoholic. Constant effort is required to remain in the fifth stage of overcoming addiction and prevent a relapse. If this happens, however, it's important to share with your patient that relapse is common, and it may take a couple of relapses before they're able to stably maintain their maintenance phase.